Hi folks, welcome back to another video. Today we're going to talk about heart failures, specifically heart failure with the preserved ejection fraction. There are different categories of heart failure based on ejection fraction. There are improved ejection fraction, mildly reduced ejection fraction, preserved ejection fraction, reduced ejection fraction. So there are like four different categories of heart failures if you look into American College of Cardiology. They're all based on EF, ejection fraction. So today we're going to talk about heart failure with preserved ejection fraction, which is more than or greater than or equal to 50%. This is previously known as, or I think still known as, diastolic heart failure, but I'm not sure if that is still a relevant term because there has been studies that shown there are multiple factors that influences this heart failure. It's just not a diastolic heart problem. It's just more than that. If you have a valvular disease or fibrosis or anything like that, it can also cause diastolic heart failure. So let's just dive in and learn more about this. So here we have a picture of normal heart, and if you look at the chambers, they're all pretty much normal size, and they have enough space to occupy enough preload for adequate stroke volume and adequate cardiac output. And we're going to compare this heart to a heart with the left ventricular hypertrophy, which is commonly seen in heart failure with the preserved ejection fraction. So here we have a picture of left ventricular hypertrophy of the heart. If you look at the first picture at the top, you can definitely see there is much smaller. The cavity of the left ventricle is much smaller than the right side of the heart, and that means that heart cannot carry or occupy as much preload as a normal heart could. And if you look at the bottom one, that's a cross section of the heart, and then you can definitely see that space between the muscles is much smaller on the left side compared to the right side. So when you have smaller space or smaller cavity of left ventricle, and if you don't have enough space to carry the blood volume that coming back. So let's say for example, left side of the heart, there's not enough cavity, and the blood is coming back from lungs to the left side of the heart, so that it can go back out to the body and perfuse the organs, right? But if you don't have enough volume on the left side of the heart to carry whatever blood is coming back from lungs, then it might back up to lungs, which would increase pressure in the pulmonary artery, and that might increase the pressure of the right ventricle too. So eventually, over time, this left ventricular hypertrophy, if it's not treated correctly, can cause pulmonary hypertension and right ventricular dysfunction, and eventually can lead to a complete heart failure. One of the diagnostic procedure to diagnose a heart failure is echocardiogram. Echocardiogram looks at the heart. It looks at the valves and heart muscles to see if there's any abnormalities or hypertrophy. And for a patient with heart failure with reduced preserved ejection fraction, my bad, they need to have an EF equal or greater than 50%, and they might have signs and symptoms of heart failure. If they have a left-sided heart failure, they might have issues with breathing, crackles in the lungs, and if they have a right-sided heart failure, they might have issues on the rest of the body, like edema on the lower extremities or JVD. They might also have elevated BNP, which is a peptide that can cause vasodilation. It's commonly seen in heart failure. They might also have left atrial dilation as a result of left ventricular hypertrophy. If you have an increased mass of left ventricular muscles, that means the end diastolic pressure of left ventricle is high, which might put pressure back on the left atrium, which causes dilation. And if that pressure persists, then that pressure might put pressure on the pulmonary artery back to the right ventricle, can cause pulmonary hypertension and right ventricular dysfunction or right ventricular hypertrophy, as we mentioned earlier. Management of heart failure with preserved ejection fraction primarily focuses on blood pressure management and intravascular volume management. We don't want the patient to have too much volume, especially in their lungs or lower extremities. So we give them diuretics. Usually we give them loop diuretics, but we can also give them other distal tubule or thiazide diuretics such as metalazone in conjunction with loop diuretics. Angiotensin receptor in combination with neprilysin inhibitor has shown much more effect in terms of lowering the mortality rate in patients with heart failure. So it has been recommended to use that medication for this patient for these types of patient. Angiotensin, as we all know, it's a part of RAS system, renin angiotensin aldosterone system. Angiotensin act as a vasoconstrictor. So if you block angiotensin receptor, then you would get vasodilatory effect. Neprilysin, on the other hand, it degrades your vasodilatory peptides in the system, such as natriuretic peptide. So if you inhibit neprilysin, then you would have more vasodilatory peptides in the system, which can also promote vasodilation. When you have vasodilation, it not only controls the blood pressure, but also decreases the afterload so that the heart can pump out the blood more easily. So that is also a part of it. Mineralocorticoid antagonist, especially aldosterone. We're focusing on aldosterone here. Aldosterone, as we all know, that keeps sodium and water inside the blood vessels, so it increases blood volume or volume in general. So if you inhibit aldosterone's function, then you would get that diuretic effect and lowers the volume. Sodium glucose co-transporter has also shown much more effect and lowering mortality rate in patients with heart failure. It also has some effect as an osmotic diuretic since it is inhibiting the glucose reabsorption. So that also has a good part of effect. Beta blockers and non-high hydropyrines, calcium channel blockers, they have and digoxin if they're hypotensive. They're all meant for rate control and increasing the contractility. And if they have a history of AFib, we wanna consider anticoagulants for these patients.